Even more importantly, what we saw were these incremental drops in somebody's cardiopulmonary performance as measured by this algorithm happened on average more than 7 days before the person ended up in hospital.
On today's episode of Let's Talk SADS Live, we are joined by Dr. Heather Ross, a legendary Canadian cardiologist, rock climber, rock musician, and full disclosure, my doctor. Dr. Ross will talk about her near-death experience that gave her a deep appreciation for her heart failure patients' lived experience. She'll talk about her cutting-edge work to support digital heart health monitoring and her life's mission to provide health equity for all. Dr. Ross is a professor of medicine at the University of Toronto, a cardiologist at the Peter Munk Cardiac Centre at UHN, and the site lead for the Ted Rogers Centre for Heart Research. In recognition for her decades of clinical work and research, she was named as a member of the Order of Canada in 2020. But more importantly, you will find Heather Ross to be warm, engaging, and passionate about improving outcomes for heart failure patients. Please welcome Dr. Heather Ross. Hi, Dr. Ross, and thank you for joining us on Let's Talk SADS Live. You and I have known each other, full disclosure, for many years. You're my cardiologist. It's going on 12 years now. But you had an experience that I think is pretty unique that you had personally. And I'm wondering if we could just kick off with that, because it's a fascinating story, and I think it will really tell our audience a lot about you and about why I believe you are the best cardiologist that has ever been.
Wow. Well, that's high praise. A lot of years ago, we were really interested in bringing technology to our program, but certain things were just not yet funded. They were approved by Health Canada, but not available for use. And one of the big ones, of course, was mechanical hearts. So we started a program called Test Your Limits. And the purpose of Test Your Limits was to raise awareness for heart health, but also to fundraise for technologies and disruptive things that weren't yet in prime time or not yet being funded. And so we thought this was a great idea, and we started with our first trip to the Antarctic to climb Vinson, which is the tallest mountain in the Antarctic. And I went with a heart transplant recipient, Dale Shipham, and our team, which was led by Yam Nuska. And it was we'd done a lot of training to get ready, and we were all very excited about the trip. Many of us had been to altitude before without having, significant issues. And what happens when you're trying to get into the Antarctic is you've got to fly in a Russian Ilyushin, which is a big, giant Russian military plane. And you land on a blue ice runway, which means no brakes. So the weather has to be effectively perfect for landing. And we were down in Punta Arenas waiting to leave, and we kept getting delayed. And so by the time we finally got into the Antarctic, we were behind schedule for almost a week, which meant that as we were preparing to climb the mountain and laying siege, if you will, to the mountain and doing our steps, which is climb high, sleep low, acclimatization, we had no time for that. Which really compressed the trip. So off we went, and I remember we'd had a day moving from a camp up to the summit camp where we carried a load and buried it and then walked back down. There's a 3,000-foot head wall, a 60-degree incline. It was quite a significant day to get the gear up, and then went back down. Then the next day we moved up to that camp with the rest of our gear. And then the following day made the summit bid. And we left the summit camp, felt pretty good. But as the day progressed, I felt I had just no energy. I just couldn't keep pace. My legs felt so heavy. And of course, I just immediately thought I haven't had enough calories. So I'm trying to popsicle a frozen Mars bar because it's like minus 40. So I'm popsicling a frozen Mars bar, trying to get some calories in, drink lots of fluid. And I just still felt really pretty awful. And we got within 200 vertical meters of the summit. And because we had a transplant recipient, we had a bunch of medical stuff to make sure the transplant recipient was going to be fine. And so we measured our oxygen levels, and my oxygen level was down in the 60s, as was Dr. Pat Murphy, who was also on the trip. And so we made a decision at that time to turn around. And Dale could have gone on. We had two guides. He could have summited. He was doing very well, but he really believed in team and felt that if we were turning back, that he should come with. And I have zero doubt that he would have summited the mountain. So we got back to camp, and they decided to sort of rearrange the sleeping arrangements because the guides were concerned about both Pat and myself. And I was doing the blog. I couldn't keep food down. I was vomiting, and I put the boots under the air mattress to raise the head up, not twigging at all to what was going on, and took puffers to try to improve my breathing. And finally, in the middle of the night, the sound of my breathing woke the guide up. And when they did the oxygen levels, I was sitting in the 40s.
Wow.
So that is a climber emergency. I had high altitude pulmonary edema, and we broke one tent and brought my necessities down, Dale, myself, and one of the guides, and went down. And unfortunately, although I improved with descent, I didn't improve enough. So I ended up coming all the way down the mountain. So it was a very long 36 hours. And it so happened that the Twin Otter was bringing another crew in. I was basically able to finish the day and get on the plane and get back to the base camp, Patriot Hills, which is just above sea level. And it was a profound near-death experience. But what I remember the most was, I am profoundly short of breath. I am experiencing pulmonary edema. I have had this for hours, and I have patients whose entire life is this experience. And it was honestly it was a total game-changing experience for me.
How did that connect you, do you think, to your patients? Did you come back changed, or was it over time that you reflected?
I definitely came back changed. And in fact, it took more than a decade to be able to comfortably talk about the experience without becoming quite emotional. I think, near death is a scary thing. And of course, that's one aspect that I think many of my patients have had: aborted sudden death, or they've had near death experiences. And, I don't think we support people well enough through that. So there was sort of trying to be better at, talking and having a conversation when these things happen, and then just understanding the quality of life and trying to put it into perspective. And so one of the things I've done since then is, we try to make all of the trainees do an exercise test. And as they're doing the load on the bike, it's to say, this is where a heart failure patient can't go any further, just to give you a sense of how limiting it is. Because otherwise people, again, it's the walk a mile in your moccasins, right? How can you possibly know what it is unless you've experienced it? I don't think you fully can, but we can do better at explaining what it's like and what that limitation feels like for a patient to go through. And certainly, even just having it for those few hours was profound.
I mean, I know you're very open and empathetic, but did you become more so? Did you let down your guard a little bit more? This patient-doctor relationship it's kind of a tough one.
Yeah, I think so. I mean, it's a really interesting thing, right, Heather? It's this, you're brought up in medical school and you're told to keep your distance, and you're told to, have that space. And I wasn't that way before the event, and I'm certainly not that way since. And I think it's hogwash. I'm watching my language here. I think it's hogwash because I do think we need to empathize, and now I can actually sympathize because that is the patient experience. And at the end of the day, everything we're about is to try to change the patient experience, quality of life and outcomes. But that is the role of a healthcare team. And so if you don't have some inkling into what that experience is, then sometimes I think it's really hard to get why some conversations are difficult. And we, you can go at your pace, and you might have these set windows of time where patients are coming in, but guess what? Patients don't fit into the little boxes. And some patients will need more time, and some patients may not be there yet. And I know our healthcare system isn't built well for that, but it is so important.
And what tips would you give to patients to improve that communication and build that trust with their care team?
I mean, I think the most important thing is to really tell us how you feel, and put it in ways that make sense to you. They don't have to. It doesn't have to be in my. Shouldn't be in my words. We always say, "Well, can you climb a flight of stairs and can you walk, 2 blocks?" Because those are standard increments that we use for the New York Heart Association class. But the simple truth is, it is your life, and the symptoms are what you experience, and what you're able to do. Only you know that, and we want to hear it I want to hear it in your words, and I want to understand what the limitation means in your words. So if your world is around not being able to walk a puppy dog, not being able to lift your child, right? Because there's weight restrictions. And how can I help you to learn to get down on the couch or to slip down onto the floor so you can still hold your child in a way that is so meaningful, recognizing that I'm saying, please don't squat and lift your 50-pound child up into your arms, right? So getting it into that space that is relevant for whoever the patient is, I think that's crucial.
This is a good segue to sort of get into this personalized approach with remote monitoring. And I know you've been really invested in this. How does that help patients and change their behavior? And, what do you see in the future for that?
So, I can circle back to test your limits, because, when we started thinking about how to try to monitor patients, and in particular, when we were thinking about how to monitor patients with a phone, it's like, no, that can't be done. No, that doesn't make sense. And of course, because of test your limits, we were able to just build the program anyway. And that's how Medley was born, which is a remote patient management app. It's a Health Canada Class 2 app, which means it can prescribe and push medications. It's built with an algorithm, and it is built conservatively so that safety being the priority. But I always thought it's anathema that this idea that I'm going to see you and I'm going to see you, and the world's going to be just fine in between those 2 points. Well, life happens between those 2 visits. And if I'm seeing the patient here and here, how the heckle am I going to know what's happening in between when life is happening to those patients? And that's where we thought we need to move from this episodic proscriptive style to a more on-demand, if we can. Like, how can we provide that? And by using a smartphone app, it allows us to see every day how a patient is doing. So instead of the snapshots being every 6 months or every 3 months, the snapshot is every day. And we've been able to show with that a tremendous improvement in outcomes. And from that, I started thinking, but that's still a snapshot, and I still have patients who change over a day, or where the weight may not be the only or the best indicator of how a patient is doing. And I was down in Cupertino at Apple, and they were really interested in their AFib app. And I had this opportunity to be in front of Sumbul Desai, who's the VP of Health. And I thought, I'm going to have this short window in front of her. I'm going to make a pitch. So I walked in and I said, I love the AFib app, but what I wanted to talk to you about was how I can use the watch to predict cardiopulmonary performance and potentially use that in heart failure. And that's how TrueHF was born, which is an app using a deep learning algorithm, using variables from the Apple Watch to predict somebody's cardiopulmonary performance, which we were able to show we can do. But even more importantly, what we saw were these incremental drops in somebody's cardiopulmonary performance as measured by this algorithm happened on average more than 7 days before the person ended up in hospital. So that, and we validated it in a Fitbit. So it raises this possibility of wearables as a way to, in a free living environment, unobtrusively monitor how a patient is doing and potentially provide a signal for when a patient's going to get into trouble. Now, that's future work, which we're currently starting, including a pilot study to look at intervening to see if we can make an impact on how patients do. But really excited about that idea because wearables, especially if it isn't strictly for the 1%, right? If it's a wearable that is affordable and can be used more broadly, and if it does provide a signal, then we really can move to this on-demand style where I meet you in the moment where you're at when you're in trouble to try to do something so that you don't end up with that event like I felt on Vincent.
Gotcha. Wow. So that's pretty revolutionary.
Yeah, it's coming out in Nature Medicine tomorrow. Yeah, really excited.
Well, and also disclosure, I was in the pilot for the True HF study. So I got to wear an Apple Watch for many months as we tested the watch in the app. It also might work as a behavior modification tool.
For sure. So there's lots of, I think we're at the dawn of digital transformation. And we use the term digital transformation to imply the use of large data, whether it be from your electronic health record, or wearable, or other smart devices, how we can use large data to help improve outcomes, including behavior modification, as well as adherence to medical therapy. But at the end of the day, Heather, this is so important because I've spent my life in working in heart failure. And so when I started, it was 1 in 5 Canadians that got heart failure. It's now 1 in 4 Canadians that get heart failure. And as a consequence, while I'm here, and I always used to make the analogy to Niagara Falls, by the time you see me, you've gone over the falls in a barrel.
Right.
And I'm under the falls trying to figure out how to get you back up. And the bottom line is we have to move upstream towards prevention. And I think how wearables can help improve everything from sleep to step count and lifestyle modifications, and how we can work towards curtailing the sedentary. The world has become so sedentary, and as a result, obesity is on the rise, and diabetes is on the rise, hypertension. Like, all of these are significant risk factors for heart failure. And when we think about stages of heart failure, I see people who have symptomatic heart failure, that's stage C. People who have problems with the heart function but don't know it yet are stage B, and that's 1 in 20 people out on the street who don't even know it. And then you have the people who we actually call stage A, which are the people at risk. So hypertension, sedentary, obese, diabetes, coronary disease, etc., genetics, congenital. So it's a really big problem. And what you can do to change your personal trajectory, and by that I mean you, the audience, is pretty wide open. And I believe it really does make a difference. And I think wearables it puts the information in the palm of your hand. It allows you to see, you can get nudges, you can track your sleep and start learning some simple behaviors that can change, easy things like sleep, which have a long-term effect on cognition and cardiac status and the heart-brain connection, dementia, much higher, vascular cognitive dementia, much higher in patients with heart failure. So all of these things come together, and I think it's a real opportunity.
Talk to me about how this can be applied more universally. Yeah. Because, I'm a lucky person. I live in downtown Toronto. I can get to UHN, 15 minutes, but not everyone is located in a large center. Talk to me about how this is changing access and equity for Canadians.
So one of the things I've had the opportunity, and again, Test Your Limits has allowed me to travel the world and get to some countries, low middle income countries. And one of the things we've seen, and I'll use Africa initially as the example, is that, desktop computers and laptop computers it's uncommon to be able to to afford that. But phones are nearly ubiquitous, and they are not necessarily smartphones. But when you've traveled in Africa, you will see all these kiosks for smart money. And it is a text-based USSD system that allows people working in one part of the world in Africa to send money back to the home village in Africa. And it is trusted and it is deemed safe with issues related to privacy. So that's a trusted system. So we got really interested in could it look like if we deployed something like Medley in Uganda. And what we did was something called community-based participatory research, which is where you go and stay in community, you understand the needs, you do qualitative interviews with patients, and you understand the environment, what their needs are, what they have available. And then you work with that with human health factors, with engineering to figure out your design process for such a tool. So we sent Jason Hearn, an engineer, and he lived there for a while. And, this mobile money, this way to send money. And we adapted Medley to a text-based system for local deployment in Uganda. And we did a pilot study of Medley in Kampala. And we were able to show an improvement in symptoms, an improvement in adherence to medication, and fewer visits to the emergency room. And we have since received NIH funding and are well on our way for a study in 6 smaller communities in rural Uganda. We've now enrolled 600 patients. And we've, as AI has advanced, which is part of what happens in digital transformation, we're looking at chatbots and other AI tools to help improve what we're doing. So, for example, point of care ultrasound, where we can do an echocardiogram and send the images around the world to somebody to read them and maybe tell the operator how to move their arm to get the best pictures so we can help make the diagnosis.
Wow.
So this is the work we've been doing in Uganda, and it's incredibly exciting. I've done this work with Doctors Without Borders as a consultant now for some time. So just today I reviewed a case for them from Africa. And so you realize that technology, especially because of extension of broadband internet access, technology can really be a game changer. And so this is how we started our work up north in Winnebago Area Health Authority and Sioux Lookout First Nations Health Authority, which is how can we leverage both in-person and virtual care together with many digital tools, including Medley, but also Apple Watch for atrial fib, patch holters, rings to assess for sleep apnea, wristbands to assess for blood pressure. And how can we use all these different Health Canada approved tools to try to provide care where people are and meet people where they're at? And this has been an ongoing project. We have seen tremendous inroads, and we do realize that our First Nations communities in the north face much higher rates of cardiovascular disease and have significant challenges to access to high quality care. And I think these types of programs and leveraging digital tools, and we started by doing Indigenous sharing circles and understanding whether this was something that was of interest to communities, and we were told it was. And when we launched Medley and then did an evaluation, we were told, I wish we'd had this sooner. And of course, people want the best care. And of course, there's distrust of the system because of, past multi-generational traumas in residential schools and 60 scoops. So it takes time to build that trust. But it's been one of the most rewarding experiences for me. And it does clearly tell me that these tools can be used to improve access to care. And when we did this with Medley, we did an evaluation and we found that in fact, Medley, which has now been used in many thousand patients, it did improve access because of the way we deployed Medley, which is we provided a phone and a scale and a cuff if people didn't have it to make the person whole. And in so doing, we were able to meet all sectors in terms of residential instability and income, et cetera. So it can be broadly applied. And I think, when you talk to patients, they would love not to have to come down and see me every 2 weeks or 4 weeks to have their medications adjusted if they can be managed virtually and using technology to enable it. And that's basically what we've been able to do. So I really, it's been so exciting to be sort of here from the start of digital transformation at Peter Munk Cardiac Center. It's been great to see where we're going, and I'm even more excited about the next 5 or 10 years.
Tell me about I think you've articulated pretty well the improvement, for someone's life. If they're quite north, they don't have to get on a plane. They can be managing their systems. They don't have to be rushed in an emergency situation. Like, the whole quality of life must just come up quite a bit. But also, this sounds like to be a cost savings, because if you're just having to supply them with a scale and even the cost of a phone, that's a lot less than, air vacuuming someone out, having to stabilize them, having to treat them. Like, what do you anticipate the cost saving for universal healthcare?
So it's a great question. And, I was up in Sandy Lake last week, and just to give people a gauge, for me to travel from Toronto and work in Sioux Lookout and then Sandy Lake, it was 9 separate flights and 2.5 days of travel. So this is what you ask a patient to do for a routine test. And I think, unfortunately, people don't even think about it. It's like, well, you need an echo, come on down and get it. Well, hello. That's 2.5 days of travel and many flights. So I think whatever we're able to do in community really matters. And we take we have an echocardiogram machine that fits in a Pelican case, and we take that into community, and we do those tests in community to minimize travel. The paradox here, Heather, is that we are finding disease that otherwise wouldn't have been found. We're finding disease that, frankly, would have resulted in, in all likelihood, death and certainly disability without ever being detected at a time when it could have been addressed and the outcome changed. So as we think about from a healthcare perspective, there's probably going to be this slight blip of appropriate transfers down for things like bypass surgery and pacemaker therapies, because we're finding that. But the long-term gain, once we sort of get over that, we've identified things that would never have been identified before, and get back to a steady state, if you will. I think the long-term gains will be tremendous, because the cost for either a whirly bird or fixed wing orange to get a patient out of communities, it's enormous costs. And that's why we think as much as we can bring into the system, we're always noodling on what else can we bring that we can fit in a Pelican case. Because my goal is to put a hospital in a Pelican case and be able to go around with my Pelican case and do there what I do here. So we continue to strive for that.
Yeah. And just to sort of circle back to your first experience, you had this very, emotional connection now to your patients. I imagine the trust building that you're creating this link. People can empower themselves to monitor their own health, recognize when maybe they've had too much sodium or too much water or something, and it's giving them some feedback. That the trust building between these communities and the medical establishment I could anticipate, only grow. I mean,
and that's obviously the hope. The team that goes, we've all had cultural safety training to try to have a much better understanding of what we were never taught in school, by the way, about what happened, and to be much more aware of it and to do a much better job of active listening. And so that is certainly the hope. And we're really excited because we have these formal arrangements and agreements now. And I think it's just the start of what we must do. It's really a moral imperative. And that is for our Indigenous communities, but it's also for rural Ontarians who also have challenges with access to care, right? So it really is something that it should allow us to change care for Ontarians and more broadly, as evidenced by the work in Uganda.
Yeah, no, that's great. And our community, the SAS community, stretches right across the country. We have a big pocket in Newfoundland, pretty remote there. So this will resonate with our group. So just to wrap it up, you mentioned a little bit earlier things that are exciting you or stuff that's coming down the pike. Give us a little preview. What's keeping you excited?
What's really keeping me excited, obviously, all the commercial wearables, we still have a lot of work to do with it, but it's the field of microelectronics. And these are sort of patch technologies, like small patch technologies that actually will be able to measure things like cardiac output and measure much more. So we're doing many measurements from a wearable through a deep learning algorithm to create a surrogate for understanding somebody's cardiopulmonary performance or their cardiac output effectively. And these are some patch technologies that will measure that directly. So I think that's a big one. I think things like earables, as they're called, as opposed to wearables that directly measure blood pressure so that we can do better blood pressure monitoring because it's such a silent killer. These are some of the things that I'm super excited about.
That's great.
Yeah.
Well, thank you so much. This has been really
illuminating.
Yeah, love the whole scope of what you're doing, and keep up the great work. We really appreciate all that you do.
Thanks for having me, and thanks for everything you're doing for awareness building and for your community. It really matters.
Thank you.
Okay. Bye-bye.